Shall we start this session? May I present the first speaker, Professor Annie Beatrick Kihara from Nairobi, Kenya. She is the president of the FIGO. The topic will be What Women Want, Addressing Solution to Women's Health Challenges in Africa.
Thank you, thank you. Hello at the back. We talked earlier on about the problems in Africa, and I said the solutions will come later. So without further ado, let us actually look at
ممكن هدوء في القاعة لو سمحت؟ ممكن هدوء في القاعة لو سمحت؟ الناس اللي في الباك ممكن هدوء؟
صوت يا جماعة لو سمحتوا.
What are some of the solutions for women's health? And I want to start by saying, as I sit here, that Africa presents an opportunity. I talked about a life course approach to women's health, and right from the maternal and neonatal morbidity and mortality, we have poor childhood development. You don't need to go very far. If the mother is not at the best, the baby will not develop at the best in milestones. Adolescence, it is very clear. The adolescent and youth population of Africa by 2050 will account for 50% of our population. And then, of course, pregnancy, making it safe with a healthy outcome for both the mother and the baby. And finally, what I call the twilight years. How do you deal with a woman in her golden age? We're talking of this when we speak to maternal mortality and the targets. Every woman, every newborn, everywhere. Some of you call it preventing maternal morbidity and mortality and early newborn action planning. These are the targets that we aim for sustainable development goals. But my question was, what do women want? So we had 1.2 million women in those hushed areas that we subjected to asking them, what do you want? What should the gynecologist provide for you? And this is what they said. Sexual, reproductive, maternal, labor, postnatal, and newborn health services. Right at the top. Increased functional and closer health facilities. Respectful and dignified and non-discriminatory care. Increased competencies and better supported health workers. Free and affordable care. Looking at universal health coverage. Medicines and supplies must be found in hospitals. General health and general services, speaking principally to wellness, counseling, information, and awareness. But you can see, women are also beginning to say power, rights, economic, and gender equality, and other requests. But you can see right from this slide, our priority speaks to the most valued investment, human capital, which is really the responsibility of all the ladies and women to bring forth into nations healthy, quality children. This is a bit busy, but it's important. You have a health system, but it has influencing factors, the social, the economic, the political, and even environmental issues. But we're now beginning to see increasingly the fragmenting of a woman to just think about her as a reproductive entity is not good enough. We need other sectors to feed in so that we have better determinants socially and a good health and well-being outcome. So these are my solutions. One, Maternal and newborn health should always remain a highest priority agenda globally. Political will is important, more so policies, guidelines, and programs. The health workforce should be competent, motivated, and to synergistically work in a good enabling culture. But we need to engage other disciplines. I long for the day we will be having conferences here, not speaking to ourselves, but speaking with agriculture, speaking with finance, speaking with other people, even education, as strategic partners in this quest. Accelerated efforts to increase norms and standards, basic and comprehensive services. We must be ready. We must be able to recognize. We must be able to respond and review women in their life course journey. Coalitions and regional formations. I am really humbled by the request and attention that you have given me to be the ambassador for Africa. Really, that weighs heavily in my heart. From Egypt to Africa. We cannot be able to say, we are healthy as Egyptians, we don't care about the neighbor. More so because you need to recognize there's a migrating populace from Southern Africa to the northern part. Do you want unhealthy beings or do we want healthy people? Addressing constraints of the 3 delays, functional referrals, increasing research. And I'll stop here for a moment. Earlier on, I showed you all the problems we have. Africa has a rich foundation for research. Rich in terms of the resource, in terms of the people, but we must collaborate as partners to make them effective. Primary health care and universal health coverage, that is where the world is going. We're not going to be left behind. I will not belabor onto the actual slide post there, but I want to really focus on humanitarian crisis. We don't have to go far. We have Israel, Gaza, Palestine, DRC, Sudan. We're in conflicts and wars. Men can move, but women and children, they suffer where they are. What is our role in this area? And this is where partnerships and innovation marry together. Where you do not have human resource, plug it with innovation, with technological embrace, which is critical. In Africa now, we are saying the Africa we want, AU-driven. And we're saying Africa needs to begin manufacturing even of life-saving commodities. Egypt, you already have them. So why don't we share in expertise and translocating a similar setting into sub-Saharan Africa? Pooled financing, health literacy in a language of understanding. I like the way you speak Egyptian and you're mixing it with English. Similarly, in my setting, how much of medicine have we changed to the local dialect? Minimum. So women don't understand what you're saying. Young people, even in this audience, speak a different language. Do we give them a language of understanding, even as we're communicating health messaging? Monitoring and evaluation, extremely important. I showed you the targets at the beginning. But who is actually monitoring? Who is doing the trend analysis? And what is the impact when these targets go unmet? But my pet peeve is advocacy and our accountability for improving healthcare services to women and girls. You must have a good workforce. So the younger gynecologist, I want to pose here a little bit and ask you, you have been trained as a technocrat in OBS-GYN, be it RCOG or FIGO giving you guidance. My question is, are you fit for purpose in today's context? With global wars, with climate change, with socioeconomic recession, with the fact you need to move more peripherally to reach the last mile. Food for thought for all of us. Solutions to food and insecurity, integrated planning, multi-sector approach. Our health system must move from health system, but to systemic thinking. Add these other sectors that contribute to our health. In fact, we should be talking about one health, one government, and then community engagement in these processes and their mobilization and marketing. Maternal nutrition, we all know why we need to look at it. More and more, non-communicable diseases, and even small vulnerable newborns, let alone stillbirths or early neonatal deaths are happening because we've ignored this very salient thing. And when I speak malnutrition, I'm thinking both undernourishment and overnourishment. Fight against malaria and HIV and AIDS. This is our war, where I come from. Promotion of climate change and mitigation and adaptation strategies. Multi-sector. It's unthinkable now if we're imagining we're going to make a difference without address to it. But we have social protection. The young must remain in school and have even safe spaces. And contraception becomes a major element in terms of averting unplanned pregnancies and also as a development agenda. We must articulate that conversation. Technology, technology, technology. Earlier on, I saw the hospital and the improvements you have made. This needs to come into Africa. And this is really the map. I'm putting this specifically to show you how much feminine technologies have moved. But is it in Africa? With the life course approach, this is a must for all of us. Moving beyond disease and wellness, everything starts with you and I, self-care. FIGO has even done a life course wheel for all of us to recognize the continuum. But we must marry wellness even into our practices. But I also want to speak to the global health security issues. Biowarfare, human migration, human trafficking, drugs. We don't seem to talk about this. So we need to focus on prevention, detection, reporting, and rapid response, and our health systems, complying with international norms and changing from risky environments. More or less lastly, I want to speak to the women, even the women in this house. Ladies, we know where our shoe bites, but how many of us are stepping up into leadership? How many of us really deal with the women in informal sector? So let's wake up as the women who are gynecologists. More research in women's health is required as an investment case, and use of local data, more or less, must be done routinely. In short, all of us must be engaged as health advocates in women's health and to act now. I will say act, and put this slide for you to show you what we are doing. In PPH, prevention and management, we are a very small core group that came together and said, we want to make a difference. So Save the Children, UNICEF, WHO, the Kenyan Society, the Midwifery Society have said, we're going to run and increase awareness in terms of PPH prevention and its management. I'll be doing this Sunday coming. The other thing is laparoscopy. Those of you who are minimal invasive surgeons, we have started a program of going to local villages. So we pile into our cars the towers, the anesthetists, the surgeons, to make sure we're training people who are already in the field, who cannot come back to the cities, but making sure we're moving in the direction of having women's health optimized for her productivity. Thank you very much.
Thank you, Professor Kihara, for this nice presentation. And our next speaker, will be my dear friend, Professor Muhammad Yahya, Professor of Obstetrics and Gynecology at Ain Shams University, and one of the pioneers in assisted reproductive technology in Egypt, in Africa, and the Middle East. Professor Muhammad Yahya will give us a talk about the future of IVF in Egypt.
Thank you very much, Professor Magid. Thank you very much. I'd like to congratulate the organizing committee, Professor Hatem. It's my department, so I am really very proud of what's happening so far. My talk today, what's in store for the IVF practice in Egypt, and what's the future of ART practice of Egypt, as we can see happening very soon. On July 1978, the world's first in vitro fertilization baby was born by cesarean section in Oldham General Hospital. It took another 9 years to have the first Egyptian IVF baby by the Egyptian IVF group. 1992, first EXI baby was born by Professor De Vroy group in Belgium. In 93, the first EXI baby was delivered in Egypt by our group. So 37 years later, what's the situation of IVF practice in Egypt? We still don't have guidelines for investigations or treatment. Doctors, there is no specific qualification. There is no assessment, no monitoring. Laboratory, there are no criteria, no personnel assessment. Transfer policy, it's non-existent now. Freezing, no law for the number or duration. Oocyte or gametes, there are no regulations for freezing of both. No procedure for disposing of frozen gametes, and there is no policy for transferring gamete in between different units. Again, there is no monitoring body to monitor what's going on, and there is no compulsory reporting system and no assessment of performance of IVF units in Egypt. So what's happening? There are regulatory changes which will affect almost every aspect of our practice in Egypt and coming very soon. It will affect where, it affects who can do it and how. It will affect the use of medication and the code of practice and supervision. If we look now, we are actually controlled by Ministry of Health regarding where to work and giving us the license to work, and theoretically it monitors the place, and if there is any violation of law and code of practice, that's the area where we are referred to, and the specification of the place is almost non-existent now. This is always going to be changed very soon. قانون المنشآت الصحية already توافق عليه وفي المجلس almost هيطلع في خلال الكام شهر الجايين. انما قانون المنشآت الصحية يمكن اهم حاجة فيه ان مش هتبقى فيه لايسنس دائمة. اللايسنس is going to be renewed every 3 to 5 years, and every time there is going to be an inspection for the facility to make sure it complies with whatever the ministry is going to say. Egyptian Medical Council Egyptian Medical Council القانون بتاعه طلع سنة 22، وده بيتبع رئيس الجمهورية وليه شخصية اعتبارية. الهدف بتاعه organizing of post-university vocational medical education process in all current health specialties and the new ones in a way that contributes to improving the quality of health services. القانون بيقول ايه؟ هو المسؤول عن الجايد لاينز، مسؤول عن الكلينيكال بريفليجز، الدكتور ده يقدر يعمل ايه؟ هو اللي بيعمل الامتحان، هو اللي بيقدر السي ام اي، هو اللي بيجدد الرخصه. اي دكتور دلوقتي مش هتبقى الرخصه بتاعته دائمه، انما اعتقد من 3 دفعات او 4 بقى بياخد رخصه 5 سنين and he has to renew it. اهم من كده ان هو مسؤول عن الاحصاء والgathering of information about cases, results of referrer، العمليات اللي بتتعمل، وبعد كده هو بيبلغ عن المخالفات دي لوزارة الصحة سواء كان العلاج الحر أو أي بودي تاني. already ابتدى المجلس يشتغل، وبالنسبة للسبيشاليتي بتاعتنا بقى في جايد لاينز، نزل جايد لاينز في الاسيستد ريبرودكشن. الجزء اللي اتعمل فعلا embryo transfer guidelines, ovarian hyperstimulation protocol, artificial oocyte activation, clinical guidelines for the number of embryo transfer in IVF. In progress بيتعمل دلوقتي diagnosis of infertility, induction of ovulation, semen examination, adjuvants, criteria for IVF laboratory, indication of IVF. Another area of change هو قانون الأبحاث السريرية. قانون الأبحاث السريرية ده طلع already المفروض إنه in effect. بيقول إيه اللي ممكن يعتبر research، ومن ضمن الحاجات اللي بيقولها any medication or procedure that's not present in the guideline is considered as research. And this is very serious. If you put, let's say, adjuvant growth hormone for IVF, and this is not in the guidelines, it has to be nominated research. والريسيرش عشان يتعمل لازم يتعمل في حتة مرخص ليها انها تعمل ريسيرش. فده is going to be very serious، لان لو حصل مشكلة you are doing research on licensed place، وده ممكن يعرضك لمسؤولية على حسب القانون. Now we can speak about the elephant in the room, the ART law. ال IVF regulation مش جديدة، ابتدت بال Human Fertilization and Embryology Act في انجلترا سنة 90، وده كان نتيجة ل a very long process بارونس وارنك ابتدتها من سنة 84، وده بيكفر اليوز اوف هيومن embryos في كل حاجة including كمان الريسيرش. الهيفا regulates monitors each clinic providing IVF في انجلترا، تعمل insemination, storage، وهيفا is responsible for licensing and monitoring all UK human embryos. هيفا grants license for up to 4 years، new clinic بتاخد 2 years، لكن طول الوقت بيحصل لها audition. في أمريكا الوضع مختلف شوية، الرابلاتري is regulated بالclinical laboratory improvement act، الدراجز بالFDA، والفيرتيليتي كلينيك سكسس ريت بيبقى ريبورتد للسي دي سي، وبعد كده هو بيتنشر. لما ابتدى يبقى في كونسيرن على ان المراكز بتقول انا عندي بريجنانسي ريت 60% و70%، طلع قانون من الكونجرس سنه 92 اللي هو Success Rate and Certification Act mandates all ART clinics report success rate and data للفيدرال جفرمنت، مش لللوكال جفرمنت، لا بتروح للفيدرال جفرمنت وبعد كده بتروح عشان تتنشر. في العالم العربي في ايه؟ تونسيا، تونس من سنة 2001، السعودية من سنة 2003، البحرين من 2017، الامارات من 2019، الاردن السنة دي طلعت قانون. احنا في مصر كان في محاولات سنة 2010 نطلع قانون، وجت الثورة حطيته في الادراج من ساعتها. ناس كتير قوي بتسأل واي IVF، ليه مش كدني، ليه مش أي حاجة؟ لأن IVF is very specific. Patient is a couple, more than one doctor. Laboratory plays a huge part في manipulation of genetic material, legal effect, religious points, ethical consideration. The effects are not always known and they may take few generations to be present. The ART law is almost done. هيتحول مجلس الشعب very soon. بيتكلم على ايه؟ بيتكلم مين اللي ممكن نعمل له ART، يتعمل فين، مين اللي يقدر يبقى موجود في البروسيدير، ايه اللابوراتوري كرايتيريا اللي هتبقى موجوده، هنقدر ننقل امبريوز قد ايه، نعمل فريزنج لايه، what are the gametes we are allowed to freeze، نقدر نشيلهم قد ايه، نعدمهم امتى، ونقدر نحولهم من one unit to the other ازاي. It will monitor all IVF units and will report the results, compulsory registration, and subsequently هيبقى فيه assessment of performance. ايه اللي متوقع هيحصل؟ definitely كلنا شايفين دلوقتي ان احنا عندنا more cases of oocyte freezing, more genetic testing is being done. When we limit the number of embryo transfers، مش هنقدر نعمل بعد كده 4 و5 والكلام اللي بيحصل دلوقتي، هيبقى في large number of available embryo for freezing، ومن هنا هيبقى لازم تبقى في علاقة واضحة بين المركز. احنا عندنا embryo's موجودة عندنا بقالنا 15 سنة، القانون حاليا غير متواجد، انا ما اقدرش ان انا اعدم الامبريوز دي على الرغم من وجود عقد وموجود consent form، انما legally it's not binding. و definitely once ان احنا ابتدينا نريبورت all cases، كل الحاجات اللي بتتقال دلوقتي عن الهيوج success rate will going to vanish. طبعا احنا عندنا challenges. We are underpriced. We are the cheapest place on earth to do IVF. Non-comparison with any place else. The cost of actual procedure لو حسبت ال IVF بالconsumables بان انت عايز تحط فلتر زي ما اللاب المفروض انه يتعمل، هيطلع اكتر من ده بكتير قوي. عندنا مشكله في السبلايز، البرايسز، الافيلابيليتي، الميديكيشن كلنا طبعا حاسين بالمشكله بتاعتها، السبير بارتس بتاعت الاكويبمنتس في هيوج بروبلم. لو بصينا على الكوست بتاع الاي في اف في اي بلد في العالم، زي ما بقول لكم no comparison, no comparison even in the neighboring country. يعني ف definitely there is something wrong in the way we put the equation. So in conclusion, colleagues, the next few months will witness a marked shift in the regulation of IV practice as we see it and we do it now. Doctors and healthcare providers should start preparing for these changes. وده الهدف يمكن من ان احنا دلوقتي بنطلع الكرايتيريا of IVF lab، لان الكرايتيريا دي هتقول ايه اللي المفروض يحصل، ازاي نستعد لها، مش هتطبق النهارده انما within a year and a half once ان القانون واللائحه طلعت هيبقى كل لاب should abide by whatever is written there. There should be integration of the small units. I can't see how a unit will run with 20 cases a month. It will never pay for the filters of the incubators. الداون تايم ما ينفعش ان تبقى في وحده IVF بتشتغل الصبح من 10 ل 11 وبعد كده هوت ال 24 ساعة الباقية ثياترز مقفولة. مكن بيستهلك أكسجين، بيستهلك كربون دايوكسيد، بيستهلك نيتروس، اير كونديشن مفتوح. It doesn't make sense. We should reduce the redundancy in timing and equipment. Thank you very much.
Thank you, Professor Yahya, for your wonderful talk, unveiling our status quo in this very sensitive area of practice. I have pleasure and honor to introduce my life-lasting friend, Professor Abu Bakr Nashar, to address us about what's new in ASHRI Conference 2024.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organized committee for inviting me for this prestigious conference, and I will take you to the Amsterdam, the last annual meeting of the European Society of Human Reproduction and Embryology. About more than 400 presentations, about 100 sessions, and we want to highlight the most important or the recent 40 articles. Regarding the electronic cigarettes, is it harmful? Yes. It is just harmful to the male fertility as regular cigarette. It will reduce the euploidy rate of the embryo and have a negative effect on pregnancy. Intermittent fasting is important? Yes. Significantly improves the sperm viscosity and the motility, and we can use it for the treatment of sperm hyperviscosity. There is a new test, sperm quality test. It is a novel epigenetic assessment of the sperm quality. It was introduced in 2022, and when it is abnormal, it will decrease the intrauterine pregnancy. What is the value of sexual abstinence? Sexual abstinence, if less than 2 hours, is associated with reduction of the sperm's DNA fragmentation and the higher pregnancy rate. We are using antioxidant for male factor infertility, but to confirm there is no benefit of using antioxidant for 3 months in infertile men. It will not improve the quality compared to placebo. We are thinking that the density gradient is better than the swim up technique for the semen processing, but according to this study, there is no difference. All of us believe that endometriosis is associated with a bad effect on the oocyte morphology, on the fertilization rate and the pregnancy outcome, but there is very long study, including more than 27,000 oocytes, and found presence of endometriosis has no effect on morphology, fertilization rate, or pregnancy outcome. One of the lines of the treatment of endometriosis is fertility preservation, but we have no clear indication what are the indications for fertility preservation. According to the French guidelines, if we have bilateral ovarian endometrioma more than 3 centimeters, it is an indication for fertility preservation. If we have endometrioma on a single ovary, this is another indication for fertility preservation. And the most recommended is oocyte cryopreservation, but ovarian tissue cryopreservation can be considered. There is a new desire, or a new, he wants to revise the ultrasonographic criteria of polycystic ovary syndrome. And we should consider the age of the patient. And he suggested that the ovarian volume, as we know, the cutoff level is 10, but he mentioned that between 20 and 35, the cutoff level should be 7. And with age between 35 and 40, the cutoff level should be 8. For the follicle number per ovary also should be related to the age. And he suggested above the age of 35, the cutoff level should be 14, not 20, using 8 megahertz ultrasound. There is what's called letrozole-resistant polycystic ovary syndrome. And in this condition, we will shift to gonadotropin. But according to this study, please don't do so, because he used clomiphene citrate in this condition, and he got 38 ovulation in this condition. Letrozole co-stimulation in normal ovarian reserve resulted in reduced the number of M2. So he didn't advise to combine the letrozole with the gonadotropin. There was a plenary session about the new guidelines for management of premature ovarian insufficiency. And this is a very nice algorithm how to define. We should do the FSH and A2, and the cutoff level is 25 international unit. But sometimes we are uncertain. And in this condition, we should repeat the FSH and to do AMH. Not only this, but there is a very good algorithm to reach the cause of premature ovarian insufficiency. Is it genetic or autoimmune? And another guideline about the assessing the fitness for pregnancy in premature ovarian insufficiency, when to allow the patient to get pregnant. What is about the thick endometrium? The endometrial thickness above 10 didn't affect the pregnancy rate or the live birth rate. And in this group, with thick endometrium, higher clinical pregnancy rate. Hysteroscopic septoplasty in patient with septate uterus with a history of previous live births, it will improve the chance of live births. He is recommended to do hysteroscopic septoplasty even if there is a history of previous live births. The diagnosis of chronic endometritis, what is new? The use of microbiome and the use of the ALICE test for diagnosis of chronic endometritis. The new definition of unexplained infertility according to the ISHRI guidelines in 2023. We should consider the age. The age should be less than 40 years. And we should consider also the adequacy of the coital frequency. And the adequate coital frequency is defined at least every 2 to 3 days within the fertile window. The pregnancy loss, please don't ask for the anti-nuclear antibodies. It is present in 30%, and its presence didn't negatively impact subsequent pregnancy outcome, including live birth rate. The systemic review, all of us are advising the obese to reduce weight before IVF. But let us to see the systematic review, including 15 randomized controlled studies. 6 randomized controlled studies found that reduction of weight has no benefit. Another systematic review and 9 randomized controlled studies found that the reduction of weight before IVF has no benefit. What is about if there is asynchronization? What is the recommended? Luteal E2 is better than the follicular antagonist to improve the maturation rate in poor ovarian responder. And in the advanced maternal age, it is recommended according to this randomized controlled study to give growth hormone supplementation. It will improve the probability of obtaining euploid blastocyst. The dowel trigger is recommended according to this study. It will improve the oocyte maturation, retrieval, and live birth rate. What is new for measurement of endometriosis in ART? The use of the new marker, the B-cell lymphoma 6, which is protein that is encoded on this gene. It is a new marker for endometrial receptivity in endometriosis. It is a biomarker for endometrial inflammation. And when the expression is high, it is associated with adverse IVF outcome. And in this condition, patient may benefit from medical and surgical treatment before IVF. The new index, or an index used before, the ovarian response prediction index, and it can be calculated by multiplying AMH by the number of antral follicle and dividing by the age. It was found there is a significant positive correlation with the number of oocyte and the M2. And when the ovarian response prediction index is more than 0.2, there is a significant prediction of obtaining 4 oocytes. And when it is more than 0.75, a significant predictor of clinical pregnancy rate. In poor ovarian reserve, according to the guidelines, the maximum dose is 300. But according to this randomized controlled study, there is no difference between 300 and 150. The progesterone primed ovarian stimulation compared to the flexible antagonist protocol, there is a difference. Is it a group 4 Poseidon or a group 3 Poseidon? If it is a group 4, it is associated with a significantly higher blastocyst rate. But in group 3, significantly lower blastocyst rate. The low-cost antagonist protocol to use clomiphene citrate or letrozole with 0.25 milligram antagonist injection up to the day of HCG injection using the flexible start approach. Compared to the agonist protocol, this low-cost antagonist protocol is cost-effective, especially in developing countries. Can we do oocyte retrieval without analgesia? According to the study, yes. If the number is less than 5, number of oocyte, in repeated IVF cycles and in natural cycle, and he mentioned that the pain associated with oocyte retrieval in this condition is mild. According to the guideline, don't flush. But according to this study, no. If there is discordance between the growth of the follicles, he recommended to do flushing. And he mentioned that this will increase the top quality embryo. Extending the time interval between triggering the final oocyte maturation and oocyte retrieval from 33 to 36 to 37 to 41 doesn't affect the ART outcome. Is there an effect of the type of semen preparation on the gender? Yes. It was found that with density gradient, the boys are more, and with swim up, girls are more. The second, successive ejaculate, can be a valid option for patients with poor semen parameters who don't wish to undergo ICSI. The second, successive ejaculate, the concentration is better, the morphology is better, and sperm DNA fragmentation is less. What about day 7 blastocyst transfer compared to day 5 and day 6? No, it is not recommended because it is associated with lower live birth rate, aneuploidy, and miscarriage rate. A statistically significant diurnal variation for the serum progesterone, and a single serum progesterone measurement on the day of frozen embryo transfer is not reliable. There is a new, what's called endosera. And this endosera is autologous platelet anti-inflammatory cytokine, cell-free concentrated growth factors, and the progenitor cell. And according to this study, subendometrial injection is associated with a good results regarding the endometrial thickness and the pregnancy rate. Frozen embryo transfer compared to fresh embryo transfer, according to the age. Lower live birth rate for women aged 35 to 39, and the higher live birth rate for women above 40. The use of the probiotic in treatment of the lactobacillus species when it is abnormal, there is no improvement. The modified natural cycle compared to hormone replacement cycle is preferred according to this study, and the duration of E2 supplementation in hormone replacement cycle, it is recommended to be more than 10 days, because less than 10 days, higher miscarriage rate. The supraphysiological serum progesterone level on the day of frozen embryo transfer after hormone replacement cycle don't impair reproductive outcome. The best protocol for the luteal phase support is a combination of vaginal progesterone and mid-luteal agonist. شكرا.
تفضلي.
Before we continue our sessions, just a quick reminder that Pfizer is hosting a roundtable discussion in Hall C to discuss respiratory syncytial virus maternal immunization with Professor Hisham Awad and Professor Ashraf Kurtom. Thank you.
Thanks for Professor Abu Bakr for his presentation. And now is the time for Professor Jean Depres from Belgium to address us on the future of diagnosis and treatment of fetuses with congenital malformation. Please.
Thank you very much for having me again and for your hospitality. I would like to give you a glimpse into the future of fetal medicine. And I speak usually about surgery, but the first big news is that medical treatment may substitute it. I will speak about new instruments, and I will also speak about improvements in diagnosis that are about to happen. You have undoubtedly read here that this medical treatment will revolutionize the field of fetal transfusion. In this first study, the group of Moïse et al., and to which we could contribute, did show that in 13 women at risk of early recurrence, no hydrops was observed and live birth was associated, and the number of transfusions was very low. But let's move to surgery. There are 3 fetal surgeries for which there is level 1 evidence that fetal treatment helps, and that is TTTS, congenital diaphragmatic hernia, and spina bifida. For all of these, there are improvements to come. The first one, twin-to-twin transfusion syndrome, a therapy that will be, a treatment that will be offered very soon in this hospital, and that is lasering on the placenta the monochorionic twin anastomosis. And this is done by minimal invasive surgery, bringing an endoscope into the amniotic cavity of the recipient and coagulating the anastomosing vessels. There are technical limitations like with laparoscopy when the vision is not good, when the fluid is disturbed, but for instance also when there is an anterior placenta. And therefore, scopes had to be adjusted and were curved, introduced into the market. But still, when the placenta is very anterior, there is still part of the placenta that we cannot see. You see here an ultrasound image, and that part of the placenta with the current equipment cannot be visualized. Therefore, flexible endoscopes are being used, but in the past, these flexible endoscopes were not good enough of quality, and therefore the image need to be processed in real time. Fortunately now, new chip-on-a-tip flexible endoscopes are miniaturized such, and there is enough light, that they can be used to coagulate inside the uterus. And you can see here at the right bottom side how far they can be curved. The problem is that they are difficult to manipulate for people who are used to conventional hysteroscopy, and therefore we are making tools that will make their use much more easy. Other innovations that you can expect is in the treatment of thoracic effusions and urinary tract obstruction. As you know, shunts are being used to deviate the urine or to empty the thorax. And we are now working on a shunt that is completely different. A shunt that would prevent dislodgement, and a shunt that has a valve inside so that the bladder can fill and empty in a physiological way. This shunt looks like that. It is still in evaluation, but you can see the blue valve inside a nitinol double-edged catheter. And under ultrasound, it looks like that. This is in sheep experiments that we have shown that these shunts can be easily inserted, can stay without problems, and the same goes for thoracic use. The next thing is diaphragmatic hernia, for which we have proposed fetal therapy. In 2 out of 3, you make the diagnosis before birth, and what you then do is rule out additional abnormalities, and that will include imaging and genetic testing. And we have standardized the ways to assess the degree of pulmonary hypoplasia, and that is done by lung measurements and liver herniation. Also in this field, you can expect innovation. This is the standard of care. This is fetoscopic tracheal occlusion, a procedure that happens under local anesthesia and fetal immobilization. And the equipment is exactly the same as we use for twin-to-twin transfusion syndrome. Into the mouth, you bring in the fetoscope, and we deploy a balloon inside the trachea. This is the standard of care as we see it today. The balloon is removed at 34 weeks to induce pulmonary maturation. And we have shown in a randomized trial, which was published 2 years ago, that in fetuses that have a predicted survival rate of 50%, and in other fetuses that have a predicted survival of 25%, that tracheal occlusion increases the survival by a factor 2.7 in severe cases, and a much more moderate effect if you do a shorter lasting occlusion. In a reanalysis of the data, we have shown that this operation, if it is done early enough in pregnancy, can increase the survival. So what is new on the agenda? Well, the problem of this operation is that the baby can be born prematurely with the balloon still in place. And therefore, at 34 weeks electively or in an emergency, the balloon is either punctured, removed by fetoscopy, or in an emergency is retrieved on placental circulation under fetal sedation. This is typically done at 34 weeks, but in 40% of the cases, this will be an emergency. So also to solve that, we have proposed a system to overcome this limitation. A new balloon has been made, which actually contains a magnetic valve. It is a valve that can be opened. You can see here on the left-hand side the balloon being inflated, but it can be opened by exposure to a magnetic field. Not this light magnetic field, but the field that you have around an MRI machine. And you can see here how the mother is being walked around the MRI machine, exposed to the magnetic field, and this will open the valve of the balloon. And we have just completed a phase 1 trial where a 100% deflation rate has been observed. This will change completely the field of fetal therapy for this condition, because this means patients can go for a one-day procedure to a center where this is offered, and then the women can be transferred back into their environment that they would normally deliver. Let's talk also about spina bifida. Spina bifida, when it is operated in utero, and you see here the standard of care, hysterotomy, does improve the outcome. It doesn't cure the disease, but it reduces the need for a ventriculoperitoneal shunt. It increases the ability of the child to walk, and this is so both early in time as well persisting into the early teenagerhood. Unfortunately, this operation comes at a big price. There are fetal benefits, but the mother takes all the risks and there are significant side effects. The main side effect is prematurity, which of course offsets also the treatment effect, but the prematurity is due to membrane rupture, which can give lead to chorioamnionitis, abruptio, but what is more important, the incision compromises the uterus in the index and in the later pregnancies, and these can be lethal complications. So also for that, the community is trying to find new solutions and moving away from large incisions, 6 to 7 centimeters, reducing the incision to 3 or 2.5 centimeters, as has been widely explored in South America and Middle America. And there is also an alternative of minimal invasive surgery, where fetoscopic cannulas of around 3 millimeters are being done to do this operation. But also there the evolution is not finished. Most of you are aware here of robotic surgery, and this is, for instance, a study from one of our researchers who developed a model to train for this operation, and we could show that when you do this operation with a robot on the right-hand side, as compared with straight-stick fetoscopic instruments, that the operation is actually more smooth, earlier, much shorter learning curve, and you can actually learn it to a non-laparoscopist. I don't think this is going to happen clinically because you need 3 ports of at least 7 millimeters, but the future may be that we do this when a single orifice robot is used, because the incision for that would be 2.4 centimeters, which is comparable to the open surgical technique. And we have shown that this again reduces the load on the surgeon, but unfortunately there are still limitations like the lack of haptic feedback, etc., and the place that you need around the fetus. We're also improving the diagnosis. When you make the diagnosis of congenital diaphragmatic hernia, you will do a karyotype, and already 10 years ago we have moved away to more higher resolution techniques, and you can see here that an array analysis yields an additional 6% of diagnosis of non-isolated diaphragmatic hernia. But as whole exome sequencing is coming, when we introduce that into practice, we will also have better selection of cases. In this study from Holland, they showed that there was a 12% additional yield of diagnoses that you could not make by conventional imaging and genetic testing. Also, fetal MRI is being introduced into our practice. And MRI is a complement to ultrasound. But in this paper from our group, we actually have shown that MRI can overcome some of the limitations of ultrasound. And that is three-dimensional reconstructions in high resolution. And in MRI, maybe you don't know that, but an MRI sequence has only one direction of high resolution. But if you take 3 sequences, you can actually fuse them together and smoothen the surroundings of the organs, and we have shown that we can actually more accurately measure the lung size, which is the selection criteria for this condition. To finish, and this is a paper from last year that we published in Nature, we did demonstrate that amniotic fluid can be used as a source to grow fetal organoids. They are derived from the lung, the intestines, the skin, the urinary bladder, and we could show that within 4 weeks after sampling the amniotic fluid, you can grow an organoid that will mimic the condition the fetus has. And you can see here on the top hand side on the right that these organoids mimic lung tissue, because we are very interested in trying to mimic congenital diaphragmatic hernia in a Petri dish. And we could demonstrate that the severity of the condition was mimicked in the Petri dish, and this will allow us to select patients better and to test prenatally fetal treatments. I would like to thank you for your attention. I would like to thank this hospital for sending these wonderful colleagues to us for training, because very soon this hospital will start with a fetal treatment program. Thank you very much.
Thank you, Professor Jean, for this interesting lecture. I think that we will have a lot of questions, but we will postpone at the end of the discussion. Okay? No, postpone it. Our next speakers will be my dear colleague and friend, Professor Sharif Mkawi, Professor of Obstetric Gynecology at Shams University, and he is one of the eminent in the field of obstetric and gynecology. His lectures about reproductive healthcare, artificial intelligence.
Thank you very much, professors. As the head of the organizing committee of the ASOGIC 27, I'd like to welcome you all. Thank you very much for being here with us in this great conference. My talk today will be about revolutionizing healthcare artificial intelligence. We'll talk today on introduction, the history of artificial intelligence, how it works. Then I'll go to its applications in healthcare, its applications in obstetrics and gynecology. Then I'll go into ethical considerations, into limitations and challenges, and finally, our conclusion and take-home message. So, what is AI? AI is the ability of a computer or a machine to perform tasks commonly associated with intelligent beings. It includes problem solving, reasoning and learning over time, decision making, and high-level computations. So, the history of AI. Does anybody know when was the first AI in history? Was it 5 years ago, 10 years ago, 20 years ago? So, the first AI system was on 1956. A new term, AI intelligence, was coined. A research field was founded at Dartmouth College with the foundation of the first AI program. Then we'll go into 1960, where the world's first autonomous robot, it was called ELIZA, where the early natural language processing program, the first chatbot in history, the ELIZA. In 1970s, we went into the AI winter, where there was reduced funding due to unmet expectations. So we'll go into 1980, where there was the first expert system which mimicked the human expert decision-making, which started to rise. It included MySyn system for medical diagnosis and ESCON system for configuring computer systems. After that, on 1997, IBM's Deep Blue system defeated the world chess champion Garry Kasparov. I think many of us heard about Kasparov. So this IB system defeated the world's chess champion Garry Kasparov, marking a significant milestone in the artificial intelligence, and that was on 1997. Until the 2000, there was advances in computational power, data availability, and algorithmic improvements. This is a photo for Garry Kasparov when he was defeated by the IBM system, the Deep Blue system, on 1997. Then we'll go into the 2010, where there was breakthroughs in image recognition, speech recognition, natural language processing, example, the Siri voice recognition. In 2011, IBM's Watson won the quiz show, the Jeopardy show, against human champions, demonstrating advanced natural language processing and information. In 2012, the AlexNet, a deep convolutional neural network, won the ImageNet competition. In 2016, the Google's DeepMind developed the AlphaGo system, which defeated the world champion player Lee Sedol in a board game, a highly sophisticated board game called Go Game. So this is the photo for Lee Sedol when he was defeated by the IBM system using the AI. In 2020, AI continues to make strides in various domains, including healthcare, autonomous vehicles, natural language understanding, large language models like the OpenAI GPT-3 and GPT-4. So, how AI works? I have a very common proverb: give a man a fish and you feed him for a day. Teach a man to fish and you feed him for a lifetime. So I'll try to apply this proverb to the machine. Traditional programming relies on explicit instructions defined by the programmer. You just give the computer the fish. In contrast, machine learning involves training algorithms to learn patterns and make decisions based on data, allowing for more adaptive and scalable problem solving. You teach the computer how to fish. So how it works? We first have data, then learning the machine, analyzing the data and extracting a model, learn from the data, and finally problem solving or prediction of outcome. So what is the AI techniques? We have first machine learning based on algorithms, using sample data to train the computer programs to recognize patterns based on algorithms. So the machine learning is based on algorithms. Next, the neural networks, where the computer systems designed to imitate the neurons in the brain. They are composed of interconnected nodes or neurons that work together to process and analyze the complex data. The natural language processing, which is the ability to understand speech as understand and analyze documents. And finally, the robotics. Machines can assist people without actual human resources. So this is the artificial neural networks imitating the human brain, where computation systems inspired by the human brain's neural network, they consist of interconnected nodes or neurons organized in layers. The basic architecture includes an input layer, one or more hidden layers, and an output layer. So we have data collection and labeling, network architecture into layers, neurons, connections, forward propagation, passing the output of each layer to be the input of the next layer, training the network to measure the difference between the network's prediction and the actual label validation and testing, and finally, the inference. So what is the application of AI in healthcare? We have many applications, including workflow optimization, diagnostic accuracy and real-time monitoring, personalized treatment, predictive analytics, robotics, research advancement, pharmaceuticals, and telehealth and telemedicine. The AI-assisted diagnosis and treatment, we have a quick medical images analysis, which gives early potential issue discovery, personalized medicine, where treatment is tailored to individuals based on genetics, lifestyle, and medical history, clinical decision support system, the CDSS, and finally, we have a predictive analysis and predictive medicine. AI in pharmaceuticals, identifying potential drug candidates by analyzing genetic, molecular, AI algorithms can predict which patients are most likely to respond to a given treatment. identifying drug interaction and potential side effects before the drug is even tested on humans. Cutting-edge robotic-assisted surgery, and by the way, we just have a couple of days ago a workshop for robotic-assisted hysterectomy. It combines the precision of robots with the expertise of human surgeons, greater accuracy and efficiency with improved visualization and control, less pain, less scarring, less blood loss, and quick recovery. For example, robotic-assisted hysterectomy, myomectomy, and ovarian cystectomy. So what about the healthcare delivery? We have both administrative and virtual healthcare delivery. The administrative is automation and managing patient record across multiple providers for a better workflow streaming. And the virtual healthcare, including wearable devices and sensors for real-time monitoring of vital signs and fetal health, giving a real-time data to the healthcare professionals. AI algorithms detecting anomalies and alerting the healthcare providers, for example, remote monitoring of blood pressure or glucose level. The chatbot uses in healthcare includes patient triage, symptom checker, patient support, monitoring, and post-discharge follow-up. Regarding the AI applications in obstetrics and gynecology, first in obstetrics we have the fetal CTG, and also we just have a workshop for the fetal CTG. But AI in fetal CTG is different. There is automated interpretation, early detection of fetal distress and acidosis, risk stratification, and continuous monitoring. In ultrasound, we went into the machines and the 5D machines. We have measurements that are challenging sometimes. Example, in obese patients, it may be solved by the AI. Semi-automated types are used. Automatic acquisition of a standard scan plane, identification of fetal structure and organ to discover the congenital anomalies. In patient monitoring, AI assesses maternal health by analyzing vital signs, labs tests, and biomarkers. Real-time monitoring and trend analysis can detect early signs of maternal complications such as preeclampsia or diabetes, or infections, allowing for timely interventions. AI-powered remote monitoring technologies enable continuous surveillance of maternal health parameters outside the clinical settings. Last, we have the labor and delivery. The AI algorithms analyze maternal health data to predict labor outcome and identify potential complications. In gynecology, we have AI in cancer detection, in surgical assistance and robotics, and in personalized treatment. And most importantly is the AI in the IVF clinics, which may assist in egg retrieval, enhance the precision of ultrasound guidance system, the gamete selection, objectively rank gametes based on quality. AI may also compute the optimal sperm-egg combination to achieve the highest success rate. In embryo selection, we have morphological and motility analysis for grading the embryos and pre-implantation genetic screening. We also have prediction of success rate and optimizing the treatment protocols. This is the uses of AI in IVF clinics. So, could AI be the bad guy? Yes, actually yes. Here is the bad guy, and here is the good guy. So AI may be the bad guy. So what is the potential risk and ethical concerns in healthcare? First, the patient autonomy and consent, equity and fairness, accountability and responsibility, transparency and explainability, data privacy and security, and impact on healthcare professions, which is very important. We may be replaced by robots in the future. Ethical considerations include the impact of AI on healthcare professionals, such as job displacement, changes in roles and responsibilities, and the need for ongoing training and education to adapt to AI technologies. The AI limitations include lack of empathy. There is no emotional intelligence, limited ability to handle complex situations, data bias and lack of diversity, privacy and security concerns, and lack of transparency and accountability. So how would we embrace the future? We must go into more innovations, continuous advancement in AI technology, widespread adoption, and increasing acceptance and integration of AI in healthcare practice. The potential impact were improved patient outcomes, reduced cost, and enhanced operational efficiency. In conclusion, AI has the potential to reshape the healthcare landscape profoundly. As technology continues to evolve, its applications will become even more integral to providing high quality, efficient, and personalized healthcare. The ongoing collaboration between AI developers, healthcare professionals, and regulatory bodies will be essential in navigating this transformational journey. Our take-home question, not take-home message, is: will AI replace the humans in healthcare system? And what are the specialties most vulnerable to be replaced? The next slide, for me, it is the most important slide. It is the take-home wish. So my wish, my big dream is, can AI unite us in compassion and understanding, prioritizing the protection of children and innocent lives, rejecting violence, ending land and homes theft, and committing to fostering peace and coexistence for a better future for all. Thank you very much.
Thanks a lot, Professor Sharif El-Mekkawi, for this nice presentation. Next speaker from Germany, Dr. Jack. He will address new concept of pelvic floor sonography, the main diagnostic evaluation tool in urogynecology. Dr. Jack.
Dear Chairman, dear colleagues, thank you very much for this invitation again. And once again, I want to say thank you very much to Professor Hatem and whole ASOGIC teams for this acknowledgement. I am deeply honored to be able to represent ASOGIC as the international ambassador to Germany and to receive this award. Spreading knowledge in the field of urogynecology is a mission close to my heart, because I believe that precise and objective diagnostic with pelvic floor sonography by visualizing of pelvic floor structures help us better understand urogynecology. And now I will present you our concept of pelvic floor sonography, and I try to convince you why pelvic floor sonography is the most important tool in the urogynecology. Our standardized interview and clinical examination allow us only a suspected clinical diagnosis. If I ask you what's the matter with this patient, I'm sure most of us would say, oh, of course, it's an easy question, cystoid cell and rectoid cell. But in fact, we guess. Because you can only see the distance of the anterior or posterior vaginal wall. What's behind is still unclear. It's our clinical depiction with our clinical suspected diagnosis. And we guess instead of using ultrasound. And now you see very quickly what's happened. It's a very useful procedure to clarify what's happened. In case number 1, we deal really with cystoid cell. And in case number 2, with rectoid cell. In these both cases, without previous prolapse surgery, of course, we prefer native tissue repair technique with colporrhea anterior and posterior. But we must not forget, the precise urogynecological diagnostic is essential for successful therapy. And our clinical finding is of misleading. And therefore, we need an objective diagnostic to choose an individually suitable surgery for each patient. And here plays pelvic floor sonography a crucial role in a differential diagnosis of pelvic floor disorders. In case number 1, we suspected cystoid cell and we planned colporrhea anterior. Sonographically, you see the bladder is still high and urethra is stretched. Sonographically, anterior enterocele can be identified, not cystocele. In case number 2, we thought of rectocele and we planned colpolafia posterior. You see rectum doesn't sink. Sonographically, posterior enterocele can be quickly identified. And this knowledge is very important to know which surgery is the best for the patient and the question mesh or no mesh. Sonography has a lot of advantages, but 3 of them are most important. First, PEF sonography allows dynamic imaging of 3 compartments, anterior, central, and posterior. And our sonography allows real-time visualization of pelvic floor structures using 3 planes, only with 2D technique. And our sonography is a bimanual examination. That means I can perform digital exam under ultrasound view, which is especially helpful in the case of complication after slings or meshes. To avoiding misunderstanding, according to all X-ray on MRI images, and the ventral area with urethra, symphysis, bladder neck, and bladder is on the left on my image, whereas rectum, pernal body, is dorsally right. It's a cranial at the top and caudal at the bottom. The sonography can be carried out pre- and postoperative. Preoperatively, it's very important to check the anatomy at rest, to exclude some potential risk factors for sling surgery, like short or long urethra. We're looking for very high vaginal walls in level 3, according to the Lenzi. What's about frozen urethra with funneling? And we are looking for varicosis. You see urethra and pronounced varicosis in level 3. And also urethra diverticula. It's very important to know before I planned a TVT. And second, our pelvic floor sonography allows dynamic imaging of the functional anatomy. We are looking for funneling because our patient with urinary stress incontinence, they don't have any problem at rest, but only on straining. You see the opening of the urethra on effort. It is funneling. It's a 100% evidence for stress incontinence. And PEF sonography is very necessary, especially for surgeons dealing with patients after modern slings or meshes. First, help us to assess surgical success by monitoring the position of optimal position of TVT. And we're looking for mechanism of action, what's happened in vivo. You see the mechanism of action of TVT. About that later. And PEF sonography allows detecting for sources of complication, such as pain, dyspareunia, or overactive bladder after sling. You see the compare and wrong position of TVT with touching to urethra and optimal position of TVT. And it is indispensable in a planning of recurrence intervention. That means you cannot put second tape as long as you don't know why the first one is not working properly. With our vaginal scan, we can perform assessment of 3 compartments very easily. We are beginning with the mid-sagittal plane of level 3, and we check the anatomy at rest. You see symphysis, urethra, bladder neck, bladder floor, and echogenic external urethra sphincter. In this basic plane, mid-sagittal plane, we perform the measurement of urethral length. It is extremely necessary in the planning of sling. And then we are looking for movement of urethra, and we are looking for appearance of funneling. It's opening. You see in this case, the hypermobile urethra and bladder neck are going down, leading to a kinking of the urethra. We don't see funneling, no funneling, no leakage of urethra, no sling. It's very easy. You see the anatomical defect of endopaving fascia only in level 3 is responsible for the formation of the funneling and leads to urinary stress incontinence. And here plays our sonography a crucial role in the determining of funneling. You see the opening of the urethra. But you see the opening of the urethra only during Valsalva. Directly after straining, bladder neck goes up and urethra closes. And such funneling is 100% evidence for the female urinary stress incontinence. No funneling, no stress incontinence, no tape. Our pelvic floor sonography represents a special kind of sonography. Why? Because by changing the alignment of our 2D transducer, we don't use 3D transducer, we can perform 3D assessment of pelvic floor using 3 planes, sagittal plane, coronal plane, and axial plane, in the best view quality, in a real time. And you see urethra in sagittal plane, coronal plane, and axial plane. The best quality of view only with 2D transducer. And these changes of the position of the probe are characteristic and necessary for the pelvic floor sonography. And you see now we have patient with urinary stress incontinence in the planning of a sling. With our standard urogynecological examination, we have no found any pathologies. With ultrasound, we can confirm the vertical distance with funneling, and we plan tomorrow sling. Question on you, did you find any noticeable in this patient? This patient will undergo tomorrow and sling. We're still missing the another plane. I tell you we have 3 planes, 2 of them is unnecessary. And in other plane, in coronal plane, you can immediately recognize urethra diverticulum on the right. And while sling surgery, we perforate the diverticulum, risking the formation of fistula. And the significance of PF sonography can also be seen in this case. The same case, patient with urinary stress incontinence in the preoperative planning of sling. And you see, with our standard examination, we didn't find nothing interesting. But with ultrasound, with the sagittal plane, you see a concave course of the urethra. Is something wrong. With our color Doppler, we can discover a lot of vessels. In cavum retsi, with a pressing of the urethra. In another plane, axial plane, please note relationship between the vessel and diameter of urethra. A very pronounced varicosis. And the risk of bleeding while the sling surgery is very, very high, especially in case of unular varicosis. And now with posterior compartment, we have diagnosed rectal cell, but we know that different anatomical conditions, such as varicosis, rectal cell, posterior enterocell tumor, can appear to some result. To check the posterior compartment, I oriented the scanner posteriorly, and you see pernal body, anterior and posterior rectum wall parallel to each other, and you see the first patient with a diagnosis rectal cell stage 3, and the question is the same question: which surgery is the best for the patient, mesh or no mesh? And using of ultrasound is very easy, because clinically posterior rectal cell and posterior enterocell cell produced clinically the same result, distant of the posterior vaginal wall. But only with ultrasound we can distinguish immediately between rectal cell and posterior enterocell cell. You see in this case pernal body and anterior rectal cell. anterior rectal cell. In this case, of course, we perform native tissue repair technique. In the second case, you see small rectal cell and big anterior cell. I introduce my scanner into vagina and simultaneously orient posteriorly. And now you see, while the patient is pressing, the rectum doesn't move. Only the intestinal loops come down. Posterior, anterior, I don't need MRI. I see immediately, and in this case, I must perform mesh repair posterior. You see small rectal cell and the movement of rectal. It is a sagittal plane, it's a standard one. In this plane, we can distinguish between rectal cell and anterior cell, but to achieve the exoanal imaging of the anal canal, I must turn our probe to the left, and now you see anal sphincter complex without introducing the scanner endoanal. The anal sphincter complex consists of hyperhergogeic internal anal sphincter and hyperhergogeic external anal sphincter. And you see also mucosa of rectum. And it's very important advantages of pelvic floor sonography without introducing endoanal. If it becomes necessary, I can examine simultaneously under the ultrasound view rectally. It is very useful. And you see, I need two planes to perform the complete pelvic floor diagnostic. Sagittal plane is the base one, it is the first one. And the second one is coronal or axial one. And very important information is the pus and the stool are the best contrast agent for pelvic floor sonography. I don't need radiation, X-ray with contrast to recognize a fistula. You see, in case number one, you see abscess of rectum with the movement of the pus. You see immediately movement of the pus. In the second one, you see defect of anal sphincter complex on the right after birth with such cup with a lot of pain. And you see two rectovagina fistula with the movement of stool. Also, you see one oblique rectovagina fistula, also with the movement of stool. And the doctors, proctologists, looking for a fistula, didn't find nothing. You see immediately without contrast agent. And you see also rectal cancer. You see internal anal sphincter mucose and carcinoma. The PEF sonography is not everything. But without PEF sonography is everything nothing. Thank you very much.
Thank you very much. So our next speaker is from Belgium, Professor Jonna Varkamen. He'll be talking to us about vaginal laparoscopy revolution, vaginal natural orifice transluminal endoscopic surgery, better known as V-notes. Welcome.
Thank you. Good afternoon. First of all, thank you to the board and the faculty for the kind invitation to the ASOGIC conference here in Cairo. I am honored to enlighten you all today on the vaginal laparoscopy revolution named V-notes. In today's lecture, I will be giving an introduction on notes and V-notes. I will explain the surgical technique. We will elaborate a bit on the indications of the surgery and then a short summary of the current evidence. NOTES is one of the latest innovations in minimally invasive surgery and is an acronym for Natural Orifice Transluminal Endoscopic Surgery. Transluminal because the axis is not directly...
Audiovisual. Screens.
There's no screen now. Yes. Transluminal because the axis is not directly through the abdominal wall, as it is in classic laparoscopy, but goes through the lumen of another organ. Natural orifice, because the technique avoids making visible scars by using natural orifices of the body to gain access to the abdominal cavity. The technique was first described in 2004 in pigs, quickly followed by the first procedures in humans, being transgastric appendectomy, and the first transvaginal cholecystectomy in humans was in 2007. In 2012, the first publications on V-nodes gynecologic surgeries appear with a number of series on adnexal procedures and hysterectomies. In gynecology, obviously, the transvaginal route is preferred, and therefore the rest of my talk will solely focus on V-nodes. V-nodes is a result of a marriage between two minimally invasive techniques, vaginal surgery and laparoscopy. By adding endoscopic visual control, V-nodes broadens the indications of vaginal surgery and thereby reduces the invasiveness of our surgery. On the other hand, this creates the only downside, that is that you need a double skill set. In order to safely implement V-nodes, a surgeon should be experienced both in vaginal and laparoscopic surgery. Now let's have a look at why we should even consider performing V-nodes. That is, what are the potential benefits? Because we make no abdominal wounds, we obviously expect less abdominal wound infections, and we could lower the incidence of abdominal wall hernias. Also, patients will have less abdominal wall pain, and we will have no trocar-related complications. In V-nodes, patients, we see a quicker recovery with a consequence, a shorter hospitalization and potentially reduced healthcare costs. There are ergonomic benefits for the surgeons as we are sitting between the legs of the patient with the screen right in front of us. When we compare to vaginal hysterectomy, it becomes a lot easier to remove the fallopian tubes and the ovaries at the time of the hysterectomy. And in case where the patient has had previous abdominal surgery, we can often stay below the adhesions and avoid extensive adhesiolysis. Here are the exclusion criteria of V-nodes. Basically, any situation where you worry about a safe access to the pouch of Douglas should be a reason not to perform V-nodes. A previous history of rectal surgery or pelvic radiotherapy, active rectovaginal endometriosis or a treatment for endometriosis, all of these can make the pouch of Douglas very unpredictable. Same for patients after total hysterectomy. Also, in cases of ovarian cancer or in pregnant patients, V-nodes should not be the surgery of choice. Virginity is a relative contraindication. It is written in the most of papers, but technically it's feasible to operate a virgin patient with V-nodes. Now let's go over the surgical technique. Over the past 10 years, a lot of effort has been put into standardizing technique, optimizing the training process, and thereby speeding up the learning curve. Here's a list of standard equipment needed to perform V-nodes procedures. As you can see, probably all of the instruments you already have at your practice setting, except for the V-nodes port, which is basically the only new device you need to get acquainted with. The first research groups on V-nodes used a self-constructed glove port, but nowadays, most surgeons use these pre-made transvaginal access platforms. Like example, this one, the GelPoint V-Path. It contains an Alexis wound retractor and a gel seal cap, which facilitates the insertion of 3 or 4 trocars and has an insufflation and smoke evacuation port on the side. Now let's have a look at the surgical steps of a V-nodes hysterectomy. Regardless of the difficulty of the case, these are the 3 phases and the 10 steps that should be followed. Phase A is a conventional vaginal phase, where we begin with the circumcision of the cervix, next the creation of the anterior and posterior colpotomy, followed by transection of the uterosacral ligaments. Now you can place the V-nodes port. The first endoscopic step, after careful inspection of the abdominal cavity and mobilizing the bowel, is to coagulate the most caudal part of the parametrium containing the uterine artery. This early ligation of the blood supply at the very start of the procedure might result in less perioperative blood loss, which is one of the major advantages of V-nodes. Then the rest of the parametrium is sealed and cut from caudally to cranially up until the level of the round ligament. Depending on whether the ovary needs to be removed or not, the ovarian ligament or the IP ligaments can be removed. The fallopian tubes can easily be reached and removed by transecting the mesosalpinx. As a ureter is easily visualized in the pelvic side wall during this part of the procedure, the salpingectomy or adnexectomy can be performed safely. Once the uterus is released completely, you can check for and ensure hemostasis. A normal-sized uterus can be removed in total by grasping it with a tenaculum and pulling it through the Alexis wound retractor. In large uteri, with the need for morcellation, or when there is a suspicion of malignancy, the use of tissue containment systems is recommended. For medium-sized specimens, which cannot be removed in toto, an automatically deploying specimen retrieval bag is useful, as shown on the left side. After catching the specimen in the bag, the edges of the bag can be guided through the vagina, and next contained vaginal morcellation is commenced using a cold knife. Also, very large uteri can and should be removed in a bag, using, for example, this contained extraction system. With bags up to a diameter of 17 centimeters and a bag volume of 6.5 liters, it takes a little bit of strategy and patience to get the specimen in the bag. But once the whole system is installed, including a plastic guard to sit in and protect the vagina, it creates a lot of space to perform cold knife morcellation, using, for example, the modified paper roll technique. After extraction of the specimen, the V-node port is removed and the vaginal vault is closed, using whatever technique the surgeon is comfortable with. The second most performed procedure in V-nodes are adnexal procedures. These procedures also contain 3 phases. In the first vaginal phase, a 2 to 2.5 centimeter posterior colpotomy is created to gain access to the abdominal cavity. A smaller size Alexis retractor is then inserted through this colpotomy into the pouch of Douglas. Then again, for phase B, the endoscopic phase, the patient is tilted in Trendelenburg position and insufflated started with carbon dioxide. After careful inspection of the abdominal cavity and clearing the pelvis from bowel loops, a salpingectomy is performed by transecting the proximal part of the tube, followed by the mesosalpinx. In the case of an adnexectomy, the first step will be to transect the ovarian ligament, followed by the proximal part of the tube, and finally the IP ligament. Small specimens and cysts up to 5 centimeters can easily be removed through the gel port, but larger specimens can be bagged first using the same devices as shown earlier. Finally, in the vaginal phase, the V-node port can be removed and the colpotomy is closed. Many gynecological procedures can be performed via V-nodes, with of course the one being more challenging than the other. And still nowadays, many publications appear on various indications. In V-node surgery, the vaginally assisted node hysterectomy, the one I described in detail earlier, is the most common procedure, and is probably the easiest procedure to start with when learning the new technique. In the group of adnexal procedures, V-nodes can be used for salpingectomy in the light of sterilization, for salpingo-oophorectomy in the case of ovarian masses or cancer risk reduction, but also ovarian cystectomies are feasible. And finally, a group of patients that can also benefit with V-nodes are the ones with ectopic pregnancy. Regarding myomectomies, V-nodes can offer a less invasive approach for the resection of myomas types 3 to 7. For the removal of anterior fibroids, the V-node port is inserted through an anterior colpotomy and likewise through a posterior colpotomy for the posterior fibroids. In the field of urogynecology, V-nodes also gains popularity. The procedure most frequently described is a V-node hysterectomy with high uterosacral ligament suspension, but also reports on sacrocolpopexy and other prolapse procedures have been published. Also in gynecologic oncology, the use of V-nodes is increasing. Omentectomy for staging in borderline or early ovarian cancer, but especially the retroperitoneal sentinel lymph node dissection in endometrial cancer is gaining interest. Even a case report on V-nodes radical hysterectomy for cervical cancer has been published, obviously only in research setting. Many other procedures and case reports on V-nodes are being published every month in every field of obstetrics and gynecology, and without a doubt, many more are still to come. Of course, case reports and case series alone cannot give sufficient scientific support for a new surgical technique. So now I would like to give you a quick update on the most important evidence concerning V-nodes. The first important publication is the HALON trial, which was the first randomized control trial on V-nodes, published in BJOC in 2018. HALON is an acronym that stands for Hysterectomy by Transabdominal Laparoscopy, or NODES. The objective of the study was to compare the new technique V-nodes with the current gold standard total laparoscopic hysterectomy for performing a benign hysterectomy. It was a randomized controlled trial, single-center, blinded, parallel group, non-inferiority study. Blinding was achieved by giving the patients in the V-nodes group sham incisions, that is, superficial skin incisions in the abdomen with the same sutures and bandages as the patients after TLH. The primary outcome of the study was a successful removal of the uterus with the intended approach without conversion. And as there were no conversions in either group, they could conclude in the study that V-nodes was equally successful for the removal of a benign uterus. Next, they looked at a number of secondary outcomes, where actually the more interesting results come from. First, if we look at surgical time, one can see that the mean duration of a V-node hysterectomy was more than 30 minutes shorter than the laparoscopic hysterectomy. Also, more women chose to be discharged within 12 hours, and consequently shortening the mean length of hospital stay. There was significantly less use of analgesics in the V-nodes group. And regarding complications, there was no difference in intraoperative complications, but a slight benefit for V-nodes when looking at post-op complications. Here you can see the FAST scores of the 7 days post-op for both techniques, and you can see that the FAST scores in the V-nodes group are consistently lower than in the TLH group. The second RCT is the notable trial, which is a non-inferiority trial on V-nodes adnexectomy. The study was published in BJOC in 2021 by the same group in Belgium, and here the acronym stands for V-nodes adnexectomy for benign indication or laparoscopic excision. The methodology was exactly the same as the methodology for the HALON trial, with again the use of sham incisions for the sake of blinding. Looking at the results, there were no conversions in either group, so one could conclude that V-nodes was equally successful as laparoscopy for a benign adnexectomy. And again, interesting results come from the secondary outcomes, where you can see that the mean difference in surgical time was 15 minutes shorter in favor of V-nodes. The use of analgesics in the V-nodes group was almost half of that of the laparoscopy group, and there was less post-operative pain. Here again, you can see the FAST scores on the first 7 days post-op, where the pain scores in the V-nodes group are again consistently lower than in the laparoscopy group. Looking at systematic reviews, the group of Suzanne Hausmans could conclude in 2020 that compared to laparoscopy, V-nodes was equally effective to the successful removal of the uterus, and that V-nodes had significantly lower values for operation time, length of stay, and estimated blood loss, with no difference in complications, readmissions, pain scores at 24 hours, and change in post-op hemoglobin. And then finally, the most recent systematic review from Marchand et al., published in February 2024, wrote in their conclusion that the V-nodes approach was comparable with the laparoscopy for each measurement they had assessed, and that V-nodes was superior in operative time, length of hospitalization, pain scores on the first post-operative day, post-op complication, and the rate of blood transfusion. So to conclude my presentation, I would like you to offer this take-home message. V-nodes is a promising surgical technique that can expand the toolbox of the minimally invasive surgeon, offering many benefits in patient recovery, pain scores, and operative and hospitalization time. However, there is still need for additional research, especially prospective multi-center randomized trials. Luckily, these trials are currently running and the results are on their way. Thank you.
Thank you very much, Dr. Joanna, for this very illuminating talk. It is end of our session.